as you can understand, everyone, was affected by COVID. And COVID, the way we look at it, I think in the adult population, critically ill adults, I think the thrombosis rate was pretty high. Almost a third of critically ill adults in the ICUs actually develop clots. And so obviously there's a need to prophylax these individuals, with anticoagulation. So when you know this kind of data and there's a bleeding disorder patient admitted with COVID, it becomes kind of a little bit tricky in terms of instituting anticoagulation. So what I did was basically made sure that our patient actually had normal clotting factor levels. So this was a patient with severe type 3 von Willebrand's disease, which is, again, a pretty severe inherited bleeding disorder. And it could be classified in the ultra rare group because, the incidence is really very low. And so this patient got replacement factor concentrate. So the levels were normalized for von Willebrand's disease. And so this patient was equivalent to another individual, without von Willebrand's disease. And once you normalize the clotting factor levels, you reduce the bleeding risk, and then it becomes safer to actually institute anticoagulation to prevent blood clots. And we were fortunate, I think we could obtain levels on her and try to titrate her clotting factor replacement at the time that she was getting anticoagulation. And fortunately, she really did not develop a clot. She was on prophylactic anticoagulation and did very well, was discharged from the hospital. So initially, she was on enoxaparin while she was in the hospital, and subsequently, she was treated with one of the DOACs and did extremely well, and currently, is doing well. So